you for the opportunity. Sunday morning, Western food, nice breakfast. Nobody wants to discuss this. So shall we just say that we agree with all that has been said before, and I will shut up? Or what we will do is, in addition to the panelists that we have, we'll ask impromptu questions to the people who are sitting over there, and I might just close the door so that nobody goes out. Okay. So let's just start. I thought, we have a RAS, we have a ROS, we have a REG, and we have ALK with brain meds, and we have an ALK with some names such as some April, some MAB and all. So I can't even pronounce that name. So I've named this discussion as a rare genomic alterations in non-small cell lung cancer. And my first reaction when I thought about all these five, abstracts that we discussed, is like, this is too much, man. I mean, how many KRAS do we see? How many ROS do you see? How many ALK see? How many RED do we see? And I thought, let's just think about the audience. I mean, I'm sure at the end of this discussion, most of them will be asleep, if not asleep. So my subsequent reaction was, let's just not make a hoo out of it. Let's just uncomplicate things. And while doing uncomplicating, let's have fun in what we are doing. So this is what we start. This is what I wanted. This is what I'm very proud about. We analyzed our landscape of 579 non-small cell lung cancer patients in the last 3 or 4 years, and what we basically found out was that there was a high proportion of there's a high proportion of TP53. There was a high proportion of EGFR 26%. KRAS was only 12%. That is something which is very, very important. It is 28% in the Western literature. The rest 10% for ALK is by and large normal that we actually see. This was the KRAS subtypes. Out of the 12% we have 32% of KRAS 12C. So this is the background of what we are going to discuss right away. And we'll start with code break case study. And I don't know why the code break K में K is capital. Maybe they were inspired by our the Saas Bahu lady. I don't know what her name is. The case series, Kabhi Saas Bhi Bahu and all, those things. I don't know. Let's just start with this study. So let me ask this question to from Kripa. I'll start with you. I actually thought, I read a post by Amola Khade that you should always sit on this side or that side, because in between you don't get to get the first question. So let me start with you. What do you think is the right unmet need incidence of KRAS in your population?
Sir, I think hardly 1 or 2 patients I have found in last 5 years.
1 or 2 patients last 5 years, maybe that is because we have not really looked at it.
Sir, because we are doing only 9 gene panel, 12 gene panel.
The Novartis gene panel actually. Yeah, the free coupon, the med genome coupon panel over there. Okay. Yes, so not many patients. Which one? Yeah.
It's not an unmet need, sir. It's a really well conducted study, showed a really good results, but most of us do see very rare to see the KRAS G12C mutation. So in our institute, when we did the analysis, retrospectively, it was discussed by HOD as well that only 12 to 15 patients are there till now in our hospital.
That's very nice to actually know 12 to 15 patients. Okay. Anybody else has a different opinion? Yeah.
You and I have seen hardly 2 cases last 2-3 years.
I think what I am thinking is that it is probably because the panels don't cover the 12C and KRAS in that actually. Because if you look at this literature that we have, KRAS is around 12% or 13% of people in 579. So we have 78 patients of KRAS actually which are there out of that 32%. And we actually are running a clinical trial right now in which we are giving Novartis wala KRAS 12C inhibitor versus
now it will improve because the drug is available and
maybe the testings will improve.
It will cover this.
Okay. Now docetaxel. Is this the right thing? Do you use the second arm is actually docetaxel, or is it weekly Pacli or weekly GEM-CARB, Nevilpine? Docetaxel 75 mg per meter square. Is that what you use in your clinical practice? A hand on your heart.
Not really.
Not really. Okay. Chetan, how much do you use?
Fit patients.
How many patients in the last 100 patients of lung cancer that you've seen yesterday? Do you use docetaxel?
25.
25, okay. Anybody who uses more? And dosi, if you use 60 milligram per meter square, 75 milligram, because the performance status of these patients will always be a suspect. So, what do you use?
Yes, in adenocarcinoma, in second line, we are giving docetaxel to all the patients.
Okay.
But for squamous, usually I start with paclitaxel first line. That's why I am not using it
Yeah,
second
so
line.
that is the problem with paclitaxel, that you don't want to use docetaxel actually over there. Okay, fair enough. Now that's the most important question: is progression-free survival a valid surrogate marker? If you look at all the trials, now you're using overall survival. Is PFS a good surrogate marker in the second line? Was it good enough? Because if you look at this, the protocol was amended to reduce the enrollment from 650 to 300. You reduce the sample size, and then you say the study was not powered for overall survival. So, do you think PFS is okay in second line in the current scenario, or you would want to still look at OS? Anybody can take this.
Sir, PFS to start with a drug is a good marker, but if it fails in a subsequent as a OS marker at the end, then we usually don't use the drug, because in a lung cancer, up to 3-4 lines their OS benefits are there.
Some comments about the trial design, and this is where I think I would like to show, this thing, that if you had docetaxel here, out of 174 patients, 23 people did not receive docetaxel prior to, there's some problem with the slides, they are not, 23% of people did not even, I think there's somebody in favor of docetaxel who was, sabotaging the studies. Sabotage. Great. Okay. No. Can you give me a laptop or something? देख लो better रहेगा. Okay, so I will just show you this. Let it go. Let's have fun. Okay. Yeah. No, it's not happening. Can you see from there only? Okay. So you all saw the results of that, and then they get this. Are you impressed with this data? Docetaxel versus PFS, 1.1 month advantage of the PFS, no OS advantage. Are you convinced with this data? We can start from Vishnu. Happy with this data, sad with this data?
We need some option against the docetaxel, because there is a variable toxicity, that is my personal experience. Some people tolerate it well, some people extremely difficult to tolerate
the
docetaxel. So we need some better drug.
But do you think with the PFS of 1.1 months and no OS advantage, you think this is a good enough choice, or are you happy with something else?
We need more data, but still I find that it is a one more drug.
One more drug now. Your thoughts?
We are absolutely not happy with the data, but we have an option in our armamentarium. Now, since the later second, third line, the options are limited here, and we have one more to add, and maybe time to come.
Okay.
KRAS inhibitors is an unmet need. This doesn't look that good in 1 month EFS, but it is an unmet need because we know KRAS mutated patient behaves badly, and we do not have much options. This is one of the options, but we need more.
Okay.
My opinion is, by the time the patient has second line option available, patient performance rates will be deteriorated. So they are happy to take oral medicine than coming for docetaxel.
So maybe if somebody is a performance status 2 or something, an oral tablet might just be useful. Otherwise, the data wise, do you expected more out of the data, less out of the data?
So the data is not so strong enough, sir. But definitely I suggest Sotrasib.
Okay, fair enough. Yeah, please.
Sir, if this PFS translates into OS,
It has not.
if not, then I will never use this cost leader.
Okay.
Just one comment which may not be appropriate, but a combination of therapy, because we know the sotorasib is now a good drug in KRAS. In future, something combination will give a better result, so this is a one more drug. I think in colon they have some panitumumab plus sotorasib just approved.
Yeah, true that. But
I remember in the presentation also it has plus immunotherapy. The second line, and that aspect is also there in the next half of combining, and maybe that is the way to go forward with the data.
But The most important thing over here is going to be toxicity profile. So if you look at the toxicity profile, you have diarrhea, you have fatigue, you have LFTs which were basically deranged, and that is there in more than 30 to 40% of patients. So it is almost like a fatinib for 45 mg twice a day. Actually, it's not that easily tolerable a drug. And one of the most important things which is also there. Next slide, please. Is going to be, if you and the trial that we are also having is the liver toxicity. So if you have given a chemotherapy, immunotherapy, and if you give a sotorasib in less than 30 days of time, the incidence of liver toxicity is, if you look at this, the blue one, 1 to 30 days, the incidence of severe events is 79%. If you look at the blue curve here. If it is the other one, it's the yellow. So you have to, this is our general practice. If you have to give sotorasib, there has to be a washout of period of at least 6 weeks or at least 4 weeks before you go ahead and give this drug to the patient. So that's a very, very important learning point as far as we are concerned. Next slide, please. This was the FDA critique of Coldbreak. I think all the WhatsApp groups and all the Twitter basically in October voted on the FDA critique. They said the median PFS was only 5 weeks. In fact, if so what happens in a trial is you do a scan at 1 cycle, 3 cycle, 5 cycle. But if you will always get a 1 month PFS advantage. But if you actually break down this into number of days, the median PFS could not, or maybe was shorter than 5 days also. It could be as little as 5 days between docetaxel and sotorasib. 23 patients in the docetaxel arm dropped out asymmetrically. Basically, they came to docetaxel. It was an open label study. What they did was they didn't take further participate with that. Or 10 more patients who were in docetaxel arm said 1 cycle and will go over to sotorasib. Investigator's discretion. The investigator assessment of PFS favored the sotorasib arm. Fourth point is very, very important, at PI discretion. So all of us who do clinical trials, if I decide after 1 cycle of chemotherapy and the patient is not responding to it, I can say let's go to sotorasib. This happened much more in the docetaxel arm, and the people got over to docetaxel. And the BICR also had to do multiple studies basically. So this was actually a very, very, very cooked up data which the trial actually found, and there was no real PFS advantage and OS advantage was not there. Although there was only a 46% shift, 46% people who transferred over there. Next slide, please. So to me, not a very positive trial. It's an option. Maybe as you said, in people who have got who want oral medication, who are not really fit, who don't want docetaxel, maybe another option, but not really good one. Next slide, please. And just when you thought this was getting over, this was what Randeep presented. Next slide. What is the right dose of sotorasib? This is 960 mg or 240 mg. This is one trial which has basically told that maybe, and if you go to the, I hope there are no Pfizer people listening, who says 100 mg lorlatinib is the right dose? Who says 45 mg of dacometinib is the right dose? Who says apatinib 40 mg is the right dose? All the drugs were decided based on the MTD, that is maximum tolerable dose, but that was for chemotherapy, that's not for target therapies. So maybe what the FDA asked them to do was, next slide please, do a trial with 960 mg and 240 mg. This was presented in ESMO virtual plenary, and which basically randomized them to 960 and 240. And any guesses for the result? Anybody? Shadil, any guesses? 960 is okay, 240 is okay, 960 is 4 times better. What is the
equivalent?
Absolutely equal. Next slide, please. And this is exactly your PFS, your overall OS, and your overall response rates numerically higher, but absolutely okay with this. So next slide. And the side effects which were there, the hepatotoxicity, again very, very important is because sotorasib is going to get approved, or we have the trials in which people will come over there. Please allow a 5 to 6 week gap between sotorasib and immunotherapy. Otherwise, the hepatotoxicity will be much more. So it was absolutely okay. Next slide. So next slide. Does the co-mutation status matter? Does only Kumar Prabhash matter, or you have, next slide please, or you have Vijay, you have Anita, none of who are there, or Nandini also who is there. None of them I can see over here. Maybe the incidence is also low in YAI conferences. So is it only the KRAS, or is it also about the STK keep? I'll start with you only, Shailesh, because you're standing to the mic side. Do you think it's KRAS STK keep also makes a difference in non-small cell lung cancer? So if I'm showing the photograph, it does matter, right? Otherwise, I would not have shown the photograph. Next one. Yeah, true. Next slide, please. Just put a next one. Just put one more. So basically, they also found out that there were co-mutations in the KEAP, in the SMARCA4 and CDKN2A. And one of my requests to all people who are designing their own panels or who are in conjunction with the molecular lab is, please ask for SMARCA4, please ask for KEAP, please ask for STK, because the microenvironment and the co-genetic mutations are the ones who are going to get very, very important in the future to come. EGFR, ALK, ROS, MET is passé now. We need to get some more this thing. So what they basically also found out was that this was actually inferior. Next slide, please. So my conclusions, I mean, sad to say, and I hope nobody from Amgen is there. It's important not to get carried away by phase 2 results. A well-conducted, well-informed phase 3 trial is also very, very important. There was no improvement in OS, there was a slight improvement in PFS. Docetaxel is still the king. It's the king Khan, which we say in the second line non-small cell lung cancer. Although I will retract my statement in the next sponsored talk that I will give. Hepatotoxicity after immunotherapy is a concern. Please have a washout of at least 30 days. 240 mg is equally good, equally effective. Code break 200 is an important step in the management of KRAS 12C mutant NSCLC. But have we broken the code? No, we haven't broken the code at all. There is much to go. Just the next slide, please. So I would say sotorasib was the one which started like Vinod Kambli and Sachin Tendulkar. We thought Vinod Kambli will go there. Next slide, please. And it actually ended up like this. This is only sotorasib, but we have much more to go. Next slide, please. Okay, we have a trial of, after having said that, we have a trial of KRAS 12C at Rajiv Gandhi. Chemoimmunotherapy, you give first line, then you have your KRAS 12C mutant, we randomize with docetaxel and sotorasib and Novartis ka K12 and KRAS 12, and then we take it forward from there. Next slide, please. Next one is about Libretto, and that's a phase 3. Correct. Yeah, if you really have to find out a subset analysis, I would say CNS activity is better, oral manifestation, 240 mg might not be a bad dose. And FDA has actually recommended that 960 mg is not the right dose, do it with 240 mg. We also have a trial of KeyVibe coming up in which combining Pembro plus KRAS. So I think it's important not to get carried away. That's what the message I wanted to say. Just because we see a 1.11, the target therapy, more is not more. That is what I wanted to show. This is Libretto phase 3 open label study design. Next slide, please. Again, selpercatinib versus carbopem. So if KRAS 12C was lesser, what is the incidence of RET in your practice? How many RET patients? We can count on the fingers actually. Anyone can say. MOC has how many? 1% maximum. So I think we also have just 3%. I can actually count. We have 8 patients or 9 patients which we have read, but we were very fortunate to give them selpercatinib when it was available for this use. It's a fantastic drug. Absolutely no harms. Very well tolerable drug. Some SGOT, PD elevations. Otherwise, absolutely fantastic drug. Very important point in the study design is that people who got chemotherapy were crossed over, and then they got selpercatinib. That's important. Next slide, please. ITT, if you can see, I mean, this trial is a positive trial, but very important. Next please. A very important thing is, so what they did was selpercatinib was compared against Pembro plus chemo or selpercatinib versus chemo. What I basically wanted to show was that, the HR was 0.465 when you give Pembro plus chemo, or 0.58482 if you give only chemo. My takeaway, and I'll ask you guys from that side, if I can ask you, do you think you will still give immunotherapy in non-small cell lung cancer alone or in combination in a RET rearrange? So tomorrow you have a RET rearrange non-small cell lung cancer, PDL1 is let's say 60%. And patient cannot afford selpercatinib right now. What would you do? Only chemo or chemo plus immuno? Anybody can. You can take this. Yes.
We had our patient where we had a post-progression of initial platinum chemo, and we are presently on Cabo plus IO.
It's on Cabo plus
IO.
Oh, fair enough. No, what I'm saying is, will you give Pembro plus chemo or plus immuno? Will you add immuno in a RET rearrange or not? That's what I wanted to show you by this slide.
Definitely
there's a role. Okay. Immuno plus chemo, he says yes. Okay.
Only chemo.
Only chemo?
Sir, immuno plus chemo.
Okay, so this slide exactly shows you over here that if you have, so just look at this, this is the ITT with Pembro, this thing on the left, on the right, and left is ITT population. So there is no difference. I mean, if you have a red rearrange, so again the point is do an NGS, do a biomarker study. If you have a non-smoking addicted this thing, there is no point of giving them immunotherapy. That's my biggest takeaway from this slide. We all know selpercatinib is better than immunotherapy, it is better than chemotherapy. But what I wanted to show in this is there is no point in giving Pembro plus immunotherapy in patients of red rearranged non-small cell lung cancer. That's my most important take from this. Next one. Again, this was much more better. Overall responses, CNS responses. We all expect this to be much more better. Next one. Next one. Safety profile, not really much. AST increase, ALT increase, a very well tolerable drug. I mean, people who have given it is a fantastic drug. Next one, please. So my conclusion of this is 3 T's. Please test. I think single gene testing is gone away now. Choose your panel very importantly. NGS is important in single gene testing. Selpercatinib is better than chemo plus minus immune in red rearranged non-small cell lung cancer. IO doesn't add much to chemotherapy in red rearranged non-small cell lung cancer. Safety signals are manageable and a bit of self-promotion. We have a trial of selpercatinib now in the adjuvant setting. So in the adjuvant setting, you do surgery, we give chemo, we test the patient for NGS free of cost. If it is positive, we give the patient randomized into selpercatinib versus placebo. On the placebo, they get when they progress, they get selpercatinib. So that's a trial. Next one, please. So from my side, it's a yes for selpercatinib. If you have a red rearranged non-small cell lung cancer, the moment you get the report and if you have the money or the compassionate access or the patient can buy, please go ahead and give them selpercatinib. Next one, please. Now, let's come to ROS rearranged non-small cell lung cancer, the road less traveled, and that is the repotrectinib. This was the Trident 1 trial, which basically is a phase 1-2 trial. I mean, again, important to say is you will never get a phase 3 trial in a ROS rearranged non-small cell lung cancer, and there is no point in doing a phase 3 trial actually. Crizotinib was actually approved on the basis of response rates. Serotinib, lorlatinib were approved on the basis of response rates actually, and this is not on the basis of efficacy. You need not do actually. Next one, please. So the primary endpoint over here again was response rate by BICR. That's again one of the very important things. Next one. So, what is your choice of drugs in ROS? Kshitij, if I can start from you only. I mean, today if it comes,
it was a crizotinib, but now this drug.
When this drug comes, we will go over there. Any experience with entrectinib or something else? Anybody has a different crizotinib it is. So right now, what is happening is that you divide the ROS positive into 2. If you have brain mets or you don't have brain mets. If you don't have brain mets, crizotinib is absolutely fantastic. If you have brain mets, entrectinib by Roche is given free. But that's only if the patient has de novo brain mets. So I think everybody is absolutely right. Crizotinib is the way to go. Next one, please. Next slide, please. And next slide, please. So this is our data about ROS. We have had 50 patients who took treatment, only 34. Remaining 16 must have gone to wherever is Delhi. It's a free world. TKI treatment was there in 25% of people, 25 people. Next one. And we had a median PFS of around 14.83 months. It was not 19 months. It was not 19 months actually. And the overall, so next slide please, was around 1 year was 83%, 2 year was 83%, 3 year was 63%. But small numbers, I must tell you, we are also giving crizotinib. Next one please. So what did we learn in 2023? Your response rates with repotrectinib was 79%, with taletrectinib is 92.5%. Next one. This is a summary of this. So, your thoughts on this? I will start from that side now, or maybe I can start with Kripa.
I think repotrectinib is most. I mean, though the response rates are very high for the taletrectinib, but repotrectinib is having a good PFS. Even the tolerability is also very good. So we have to offer repotrectinib.
If this drug comes to you, you will be happy doing this one. Anybody else who wants to hold off with crizotinib and then go to repotrectinib? Anyone else?
Sir, as you said, it's about the brain metastasis. So if we have a brain metastasis, obviously the repotrectinib.
Fair enough. If you have a brain metastasis, you will definitely want to go for repotrectinib. Even if you don't have the median, next slide please, the median PFS is actually 34 months, which is only 19 months in crizotinib. So if this drug is available, we will obviously want to go ahead to repotrectinib. There is something called as G302R mutation, that is akin to the L1202 mutation in ALK positive. Next slide please. And what is very important on the left side is we think lorlatinib is an absolute fantastic drug. It will work against everything. But please see on the right side over here that lorlatinib does not work on G2302R mutation. It doesn't work over there in ROS. That's very important. Next one please. And if you look at the repotrectinib, the overall response rate was 78%. Next one. And in 58% in the ROS1 G2302R mutation. So this drug works in the first line, this drug works in the second line, but depending on the safety and toxicity profile, if you have that drug, I think you should definitely go ahead and give repotrectinib in the first one. Next slide please. So my conclusion is repotrectinib is a clear winner in Trident phase 1, phase 2 trial. You're getting the drug approved because of that. The median PFS, ORR, IC response rates are higher. Toxicity profile is manageable. It is active against the G302R mutation. It beats lorlatinib. Finally, something is there who is beaten lorlatinib in ROS rearranged non-small cell lung cancer. It can be called as a new lorlatinib in the ROS subset actually. Next one. And keep on doing. So this is a favorite slide which I have used with multiple people. Next one. If this was ROS rearranged, this was crizotinib. Repotrectinib is absolutely the way to go over there. Next slide. Next slide please. Now, INSPIRE was a phase 3 open label randomized multi-center study. Can I ask, just go to the previous slide please. Can anyone tell me the spelling of this new drug? Without showing this. I'll ask Randeep. Can you tell me the spelling of this drug? IRPLABCDEFGH. That is what I tell my daughter. So I think next slide please. Okay, so this was a study which basically compared, again very important is, a lead-in period was allowed, 180 mg OD, but then you have a lead-in of 60 mg, almost equal to what you do with brigatinib. You don't start brigatinib at 180 mg, you start at 990 mg against crizotinib. Next slide please. And again the PFS was improved, the OS was improved, the PFS was improved, and the internal activity was there. Anybody's thoughts on this side? We'll start with that side. We'll start with you on that side. And your thoughts on this abstract?
EG नाम available.
It is not available. It's a Chinese drug.
EG names available अपने पास ALK inhibitors में. I will EG names.
You want easy names. We'll go to IMAP. We'll like you have iPhone, we'll get an IMAP. Okay, but your thoughts on the abstract? I mean, you think
it's looking good, but again, as I was discussing, everybody is comparing with that poor man crizotinib. They are not having dare to compare with the lorlatinib or alectinib, which is available since long.
That is what happens in the corporate world. When you have been 10 years, you are useless then. I mean, all the people in corporate world will agree with that. Next one, please. I totally agree with you. Next slide. So my conclusion on this was it is yet another ITKI in the horizon. It was compared with crizotinib. What you said was right. The favorite whipping boy of ITKI. I mean, I'm actually going to call crizotinib the whipping boy. जिसकी इसको बैंड जानी होती है ना. Like Rajkumar Yadav once said, मंदिर का घंटा होगा. crizotinib की लाओ सके से लाओ और उसकी बैंड बजा दे लो. It is not compared with second generation TKIs. It may be useful in specific mutations L1196M. Doubtful, no role when alectinib, lorlatinib are available in the Indian setting. Next slide, please. And to me, why this trial was conducted, I don't know. So why this collaborative? Next slide, please. This is like a favorite whipping boy of crizotinib. Next slide, please. And it's a Me Too drug, it doesn't really add. Next one, please. So why this trial was done? Next one. Second and third generation TKIs have been. Next slide is winning crizotinib. No new efficacy has actually been achieved by giving this trial. So that's my conclusion. I have a next talk, so I'll take 3 more minutes, so you can subtract my take on this. Next one. Next one, which was not presented, but still it was there, was characterization of CNS clinico-genomic outcomes in ALK positive non-small cell lung cancer patients with brain mets, which were treated with alectinib. So people with alectinib, I don't think the presenter is here, so I only will tell you what happened. Next slide, please. So what they did was, it was a retrospective study, and please look at the timelines over here. From 2012 till 2021, over a period of 9 years, they had only 38 patients. And you look at our own data, and we are so, we think 38 patient ka data hai, kaun lega, kaun nahi lega, but just look at this. 9 years, 38 patients with brain mets, and I'll show you my data. We have 17 or 18 in the last 3 years. So next one, please. So my first thing is, look at this duration of study for 9 years, retrospective data, still a publication. I don't know why we don't publish. I think we should publish, and this is what I've learned from Kumar. That please next, give me 2 more minutes. Again, 38 patients were taken. 26 patients got only electrolyte, and 12 patients basically got electrolyte plus local therapy, including surgical resection, SRS alone or whole brain RT. Next one, please. So, can I ask from here this side, Kshitij, what is your practice? If you have a symptomatic or asymptomatic met, how do you treat a patient of non-small cell lung cancer with alcohol rearranged?
Yeah, suppose it is a non-symptomatic brain mets, directly start with TKI, alectinib or lorlatinib.
Okay.
If it is extensively metastasis more than, I think, 1 centimeter of brain mets,
Then you go ahead
with the local.
But have you reduced your radiation referrals, and have you reduced your neurosurgical referrals with lorlatinib and alectinib are available? You?
Nowadays, yes.
Yes, we have. It's okay. It's absolutely okay.
So definitely, if it is asymptomatic, then lorlatinib is the solution, and with this we have reduced our need for local therapy
Or local. So again, the more important thing is the whole brain RT has to come down. You have picked up the mic.
So with the advent of lorlatinib and alectinib, which are very CNS responsive drugs, so we quite drastically asymptomatic brain mets stop sending. When we repeat it after 3 months, it's almost near CR. So
the requirement on the whole brains and the SRS and neurosurgeries actually have come down. Next slide, please. Next slide. Okay, this was the PFS. I mean, this is something which is very, very important, which is there. Intracranial progression-free survival, if you give ALT-TKI plus local treatment, without if you give, is absolutely similar. The overall survival, but the numbers is better with ALT plus TKI, but it is not statistically significant. Next one, please. So, next one. If you look at this, the median PFS was 49 months, and the intracranial PFS was not different in both the arms. Next one. Intracranial response rate with alectinib alone plus minus local treatment. Next slide, please. This is almost similar, that whether you give alectinib alone or you give alectinib plus radiotherapy. I mean, this is again for my clinician colleagues, that we will that we have to say that if you don't give RT, it's absolutely okay. The response is okay. Next one, please. So, interpretation of this data, anybody will want to venture, and then I'll give you my thoughts on that. Kshitij, last few comments on this, and then we will wrap up. You have comments on the role of RT in clearing non-small cell lung cancer?
It's coming down and down because
it's
of that.
Coming down and down. Anybody else wants to add?
I agree with it, like, stop refers to articles.
Okay, next one, please. So the point over here is, this is my they say that deferring upfront radiotherapy is reasonable for patients with small brain metastasis or asymptomatic CNS disease, and the larger lesions, symptomatic lesions, have to be handled with local therapy. To me, the takeaway from this is, next slide please, is no guilt. If I don't refer a patient to radiation oncology or brain meds, my guilt feeling, there is no data. This is some data which actually takes away the guilt away from me. Next one. This is our data again. We have 57 patients of alectinib with non-small cell lung cancer, first line. Next one. Yeah, our median PFS is not yet reached. The mean was 34.2 months, 1 year 80%, 2 year 58%, 3 year 46%. Next one. If you have brain mets, if you don't have brain mets, it does not really change. So it's absolutely okay. Next one. Overall survival is absolutely okay. It's not reached till now. Most of the PFS was very, very good. So getting good data in the real world scenario, but most of these patients are PS1 or PS2. Next one. Again, brain mets, it doesn't really change. Next one, please. So my conclusions: the diagnosis of brain mets is no longer a death sentence. Second and third generation TKIs have excellent intracranial disease control. MRI brain diagnosis should be done in all patients. Symptomatic more than 3 cm, do surgery, give SRS after that, and give TKI. Symptomatic less than 3 cm, SRS is absolutely okay. Asymptomatic CNS penetrant TKI is the way to go. Next one. To me, I am no longer afraid of brain metastasis. That is my take on this. Next one. And to conclude, thank you for learning, thank you for having a fantastic discussion, and thank you the organizers, although none of them are here, because of this I made up and looked at my data. So thank you other panelists. Any comments from the panelists we have? Or you're glad that it is over? They're glad it is over.
Excellent panel discussions. So what we learned is not just knowledge, but we understood that a lot of trials are going in RGCA.
Yeah, that was self-promotion. So that is where co-genetic mutations. I forgot that reportractive data trial is also coming to RGCA in 6 months' time. Thank you.